Ok, dando inicio al siguiente módulo, tenemos como título Experiencias Internacionales y Lecciones para México. Nos acompaña liderando a la doctora Felicia Marinol. Tenemos a la embajadora Sally Cowell, a la maestra Liliana de Lima. Tenemos a Didrik Lohmann, que es director asociado de la División de Salud y Derechos Humanos de Human Rights Watch, y nos acompaña, y le damos las gracias por estar aquí, al doctor Alfonso Petersen, que es secretario técnico del Consejo General de Salud. Bienvenidos y muchas gracias.
Muchísimas gracias nuevamente a todos y a todas. Y primero solo decir que gracias a los doctores Atuni y Daniel, I think they just wrote our entire Lancet report, as well as started the además, tengo el gusto de estar sentada no solo entre amigas y amigos de México, también entre tres de los líderes en lo que ha sido y será este mundo. Pero además, pues ahorita que la demora, porque pues les saludo a compartir con nosotros esta mesa para comentar un poco, después de escuchar los paneles, sobre qué podemos aprender de lo que está pasando en los países alrededor del mundo, en los estados de México, donde yo considero que es tan importante que estemos implementando y actuando. Que si bien necesitamos, porque estamos dar luz realmente una política pública federal nacional hacia cuidados paliativos dentro de lo que es cobertura universal en salud, el siguiente paso es quizás lo más clave de los desarrollos también, y es cómo logramos que eso empiece a formar parte de lo que es la política pública en los servicios de salud en los estados, y no hay alguien mejor para comentar sobre eso sino el doctor Pecho. Y también aprovecho para decir que la historia de Doña Rosa que les comenté fue gracias al trabajo de Pecho para darnos espacio para intentar renovar la prestación de servicios, tanto en cuidados y tratamiento de cáncer como en lo que es contribuir. Entonces no está en el programa porque no sabíamos si iba a estar aquí con nosotros, pero con la suerte que sí, empecé a acompañarnos. También aprovecho para decirles que no sé si puedo comentar un poco sobre el informe que saldrá, pero que yo les voy a invitar a que va a ser una super presentación de un increíble informe. Y más allá que presentar a cada una de las personas, lo que solo quiero decir es un momento sobre cada uno de lo que han dado a lo que es el trabajo global. Empiezo con Deirdre por lo que es este informe que va a tener un impacto impresionante, y antes seguro que será un impacto impresionante. Yo creo que pocas veces he conocido a una persona que invierte tanto en conocer el país donde está trabajando, que no es su país, y realmente ha logrado entender el sistema de salud de una forma que me parece increíble para alguien que realmente nunca ha vivido en México. Entonces es un amigo del sistema de salud y para siempre por todo lo que ha invertido en conocernos. La doctora Liliana de Lima me ha ayudado a entender las entrañas de todo lo que es este movimiento global para cuidados paliativos y control de dolor, que como ustedes saben, cada movimiento tiene sus entrañas y entenderlos es difícil, y yo soy novicia en esto, y sin el apoyo de Liliana, creo que yo y muchos otros no hubiésemos podido, y ella ha tomado el papel de coordinar todo lo que es técnico, todo lo que está funcionando. Y mi amiga Salicao, quien cuando me llamó para decir que iba a entrar en el mundo del cáncer como vicepresidenta de la American Cancer Society, pues yo empecé a hacer lo que hace mi miedo, ¿okay? y saltar del aire, porque nunca pensé que iba a decidir pues cambiar y invertir, la verdad, décadas de conocer en particular a México y a la región de América Latina y el Caribe, y aplicar este conocimiento al tema del cáncer. Ella junto con su colaboradora, han garantizado que hay en el mundo del cáncer un espacio para lo que es cuidados paliativos. Pues con eso empezamos con nuestra organización y entiendo que
Muy bien, y muchísimas gracias, Alicia, no únicamente por esta introducción tan calurosa, pero también por invitarme a participar en esta conferencia que me parece de importancia mundial. Realmente, gracias por la invitación. Para mí es un gran placer estar aquí de nuevo en México después de algunos años en que no he tenido la oportunidad de visitar a uno de mis países favoritos en todo el mundo. Entonces realmente es un gran gusto también oír del secretario y del director de este hospital tan bueno lo que están haciendo en México para realmente combatir el problema de la brecha en el proveimiento de tratamientos paliativos y control de dolor, porque me parece que es muy importante. Porque sí, realmente yo creo desde mi experiencia es tan importante tener para cualquier persona en el mundo su dignidad. Es tanto importancia de los alimentos o el agua. Y nosotros sabemos que sin control de dolor es realmente imposible tener dignidad. Y por eso a mí me parece que la conferencia viene a un momento muy importante. Y con esas algunas palabras de introducción en español, con su permiso, yo voy a presentar algunas observaciones y de comentarios de mi programa Treat the Pain sobre lo que está pasando en otros países en inglés. Entonces, thank you. So, Treat the Pain is a program of the American Cancer Society really to look at supply and demand issues in pain relief. Of course, we need to see pain relief as a matter of human dignity and as a matter of human rights, but it's also, pain relief is a matter of looking at the same issues of access to medicines that we find in other aspects of healthcare. So we want to look at it as supply and demand. So we've already heard from other speakers this morning, and I congratulate the last two speakers for their very astute presentations about what's happening in the world of palliative care and pain relief. And we saw from Dr. Atum's slides that the number of opioids are being prescribed and being used are staying fairly constant in the developing world while they're rising in countries such as the United States, Canada, and Australia. And of course that's particularly unfair because just looking at two diseases, HIV and cancer, they are becoming, already are and becoming ever more so problems of the developing world, so that 71% now of all the deaths from cancer in the world are not in those countries where pain relief is being provided. They're in the countries which have really inadequate access to pain relief. And as we know, for some time now, almost all of the deaths from HIV are occurring in Africa, Asia, and Latin America, where there is very little access to pain relief. So 71% of the cancer deaths, 99% of the HIV deaths, and yet just 7% of the opioids worldwide are being provided in these countries. So we can address the problem from a human rights perspective, from a human resources perspective, from a regulatory perspective. Our approach in Treat the Pain has been to look at it as an issue of access. And so we focused on a very pragmatic approach to overcoming administrative and bureaucratic processes that govern access to all medications. And the way we have looked at this, and it's a very complicated slide, and I'll try to explain it a little bit better, but we hope in terms of making people remember some of the steps that are necessary. We've chosen with a little bit of having to force things into categories, but we've looked at access through defining it as morphine. And so the most important, and I think we've heard this from both Professor Daniels and Professor Atun, this is a slightly different perspective on it, but we really need to involve so many parts of the public sector, the private sector, the patients and caregivers themselves, and certainly civil society organizations, if we're really going to be able to address the problem of providing pain relief. So the first one is the M in morphine, or the M, is really for the political process. It's for the mindset. It's for hearing, as we did from Subsecretario Gonzalez this morning, that there's a decision in a country among the policymakers that despite the issues that might be faced in the provision of opioids, that is, that they can be diverted perhaps and used by medical professionals or others in ways that they shouldn't be. In a country like Mexico, which faces problems certainly of drug trafficking, it's very important for the public, the policymakers, the diputados, the president, the secretarios, a whole of government understanding that despite the problems that might occur, people who are in pain need and deserve to have some method of pain relief. So it's a mindset. The second one is to organize, to understand that there are stakeholders across the board, and we need to understand what each of them can do to limit the barriers to access that we now face all around the world. The R in the morphine is for regulations. Sometimes we see that regulations aren't brought up to date. As Professor Daniels said, things that the WHO talked about just a few months ago already seem to be out of date. So we need to be looking at regulations, and I think that's both universally and within each country, and insofar as countries have provinces or states that are important, then within those states, within hospitals themselves, what are the regulations? How do we handle things? Procurement. Procurement is also a very big issue. We know that these drugs exist. They are off patent, they are very cheap, they are on the WHO essential medicines list in almost every country. And yet in many countries of the world, there haven't been opioids procured in years because palliative care and pain relief haven't entered into the mindset. So we don't do a very good job at procurement. I remember when I first was working in the AIDS movement, and we talked about, yes, prevention is terribly important and we won't treat our way out of this epidemic, but it also became necessary and obvious that without treatment we wouldn't achieve the goals that we wanted to achieve either, because who would ever want to be tested for AIDS or screened for cancer if there were no treatment available? So we began in the AIDS movement, again, a lesson that Dr. Toon pointed out, to begin to address the issues of supply and demand for antiretroviral treatment. And there were many who said it couldn't be done. Forget Africa. They'll never be able to get these drugs. People don't have wristwatches. They won't be able to take them. But just working away one step at a time, what do you need to procure the drugs, is a very important part. So procurement, how are you going to get it? What's your supply chain? The H in morphine is for the healthcare workers. Opioids need to be prescribed. We heard this morning from the Subsecretario de Salud that there are only a few of the medical school faculties in Mexico, a very enlightened country, which are actually having obligatory training on palliative care. So we need to begin to really train health workers. And I must say, not just the doctors, but also the nurses and the social workers about the need for pain relief. The next thing to do is the initiation. You have to get it off the ground. You have to prove it can be done somewhere. So usually we try to start in the major hospital or hospitals, a leading teaching hospital, and then go out, and I look forward to hearing more about what's happening in the states of Mexico, but to go out from the centers of excellence to the more rural areas where most of the patients who need this kind of access actually live. We heard about a very important intervention in Jalisco this morning. So that's what nationalization is too. Get it started and then get it done. Prove the concept and then get it to scale. And finally, the last part of this is the empowerment part. And that really feeds into the mindset. So it's really a big circle. We need a movement. We need to get people empowered. We need people to say, this is my right. So empowerment is the next thing. Oops, I'm going in the wrong direction here. So what do we do to treat the pain? We provide some technical assistance. We work to lower the price and get a supply at a constant rate. We've been doing a program of pain-free hospitals where we start with one hospital, the national hospital. In many countries in Africa, for instance, Ethiopia has one cancer hospital. It has 86 beds. It has 86 beds for a population of 86 million people. So we're beginning to work hospital by hospital. And we've just started this program a couple of years ago. So we're now working in Kenya, Nigeria, Uganda, Ethiopia, and Swaziland, and looking at where else we should work. I should probably give this up because I don't seem to be able to do it very successfully. I guess he's telling me I only have a very few minutes left, so I will probably dispense with the rest of this and just share with you a video about an experience that we have been working on for some years now in Uganda. And I think, David, you have a little video that we're going to gear up and show you about what Treat the Pain has been doing in Uganda. Let me just say in context that this was a video which we produced primarily as a way to raise money from the American people for a need in another country around the world, that is Uganda, but also to raise attention and raise awareness among the American population for the tremendous equity gap that is persisting between what we have access to in terms of pain relief in the United States and what's happening in other countries around the world. So we used last year the occasion of what in the United States is called the Super Bowl, which is, as many of you may know, a big football championship. It takes place in January each year. So we did this video and advertised it fairly widely on American media to raise attention to the problem of pain relief in one country, Uganda, and to offer people the opportunity to support this. One of the things we have at the American Cancer Society that I'm determined to sort of make a force in global public health is a large number of dedicated volunteers, some 4 million of them. And we're trying to extend their vision and their generosity beyond the United States to look at some other countries in the world. So please share with me this video about pain relief in Uganda. Sorry, I'm not sure what I'm supposed to do with this video. David, can we run the video?
Yes, one second.
Okay. Well, you see, I had more time than I thought to.
Si hay alguna pregunta específica mientras ponen el video.
Bueno, yo tengo una. Sally, if you had to summarize, what could Mexico learn from Uganda?
What can Mexico learn from Uganda? Well, I would have to say that Uganda can probably, at this point, learn more from Mexico than vice versa in pain control. But I think it's probably awareness, getting the word out, making sure that we're empowering not only the patients to really know that they have a right to have their pain taken care of, and also their caregivers and their physicians to be really pressuring their government to overcome what in Uganda was a situation in which pain medications had not been procured for several years. So.
El subsecretario de que espero que
podemos analizar más en la sesión de la tarde, que es el acceso más, voy a usar la palabra fácil, pero con comillas, hacia los medicamentos que se necesitan a través de rutas críticas mucho más eficaces y eficientes de los que tenemos en este momento. Cuando yo pienso un poco en el caso de Uganda, lo que me ha compartido es eso, es que como en un país donde había nada, de repente se logró incluir la Interpol para ya poderlo distribuir.
This is Uganda, and these hysterical children are chanting Kiwi, Kiwi, Kiwanuka. They're chanting for this enormous man here, Matthias Kiwanuka. And that's his wife, Tessa. The kids are psyched because he just built them a new school. Now, when he's not building schools in Africa, he plays defensive end for the New York Giants. Matthias has deep roots in Uganda. His grandfather was the first prime minister, and a lot of his family still lives there. This is his family here. Well, not those two white girls. They're not Ugandan or related to Matthias. The reason we're in Uganda is to bring some attention to the nonprofit those ladies work for.
I'd say Treat the Pain is an organization that is bringing palliative care, bringing drugs, specifically morphine, to people who don't have access to it.
Okay, let me say that again. We're in Uganda with Treat the Pain, a program of the American Cancer Society, and they work to provide access to pain relief. Okay, don't stop watching. If a pro footballer can give this much energy to the cause, well, you see, this program, what they do, it's tough to talk about. They work with organizations to provide pain relief to dying people.
You know, at some point, we are all going to die. And if you're dying from a sickness or an illness, you're probably going to have a lot of pain. In the United States, we don't think about it because you just pull a button and somebody gives you a pain reliever. But around the world, in places like Uganda, there are people who are literally dying without any medication at all, which is a horrible way to even think of passing.
Treat the Pain works to improve access to pain relief for people dying of AIDS or cancer. Because the only thing worse than dying of AIDS or cancer is to die of AIDS or cancer with no access to pain relief.
And we talked to a number of people who said, without this morphine, I would have, no dignity. I would have a hard time getting through the day to day, hour to hour, minute by minute, because the pain is that great.
The thing about this problem, the lack of access to pain relief, is that there's a solution, kind of an easy one. And that's to get more medication to more people who need it. And by working with organizations like Hospice Africa Uganda, that's what Treat the Pain does. There's no shortage of problems in this world. You can't solve them all. Why care about this problem? Because it's fixable, and it gives people their dignity.
Muchísimas gracias a la Salvador Liga de México y a la American Cancer Society por esa posibilidad de seguir colaborando. Esperemos el año entrante tener un video sobre. Trabajamos con el Instituto Nacional de Salud Pública y estoy viendo a la doctora Magaña. El año entrante sí tendremos uno para México. La maestra